As I sat here this morning, I thought two things. One, what a great group of people to sit and share the morning with. But two, how lucky are we who live in the state of Arizona to now have two scientific organizations available to us in this state for cancer clinical trial care. So welcome, MD Anderson. Mayo Clinic is being one of the premier oncology centers, academic centers. We're glad to have you here. And I think it actually helps our patients. I'm going to talk a little bit more. Dr. Shaw actually gave some of my presentation, but I'm going to say it again because guess what? If you hear it once, you might remember it. If you hear it twice, maybe it'll stick. So we're going to talk a little bit again about the phases of clinical trials and what we can do to change practice, but also build hope. And that hope is you're paying it forward to patients who come after you. Oop. What I'd like to do is, again, describe the phases of the clinical trials, and then discuss the importance of clinical trials in the care of all patients, but especially today in myeloma. And then talk a little bit about what are the opportunities that we have as providers. I as a nurse, the physicians who are in this room, but especially you who are the patients, who are the end product of all the science and the research that's been done over the course of time. Let me give you a little bit of my background. I came to Arizona 18 years ago from the state of New Mexico. So I didn't move very far, but I came to a community that was pretty much in its infancy. Mayo Clinic had just gotten here a couple years before I came. And in fact, when I was recruited to come here, they asked me would I like to move to Arizona, and I actually thought I was coming to Banner to interview because Banner was the big hospital in Arizona. But it was Mayo Clinic, and I said to the recruiter, "Are you sure? They're only in Rochester." And that was the beginning of my experience at Mayo Clinic. For about 10 years before that, I'd actually worked at a community hospital in Las Cruces, New Mexico. And I had the opportunity to take care of myeloma patients, some who did very, very well, and others who died within 6 to 10 months of their diagnosis. And I always wondered why. Why do some people do so well? Why do others not do so well? And others do better? Well, now I know why. Because myeloma is not equal in all patients. There's a difference in myeloma with the cell markers, and there are people who are low risk, intermediate risk, high risk, and the treatments we've learned to give to patients have helped to increase survival. So, what is a clinical trial? Well, it's a study that actually looks at the medical and scientific questions to help learn about the treatment of disease. Some of the work that's being done is actually looking at the cell marker, the biology of myeloma, and making us smarter in developing drugs that are actually able to help care for and treat the disease. It investigates new methods of therapy. We've heard that all morning long from Dr. Shaw and Dr. Kyle, that there's new methods, new medicines being developed. The reason they can be developed is because we're learning more about the disease itself. We test the success of those treatments for that disease. And it's diseases of every kind, shape and color, diabetes, heart disease, all of those things have clinical trials attached to them. So we get smarter as we go along in taking care of those of us who have those particular illnesses. Clinical trials also find the method to the mad scientist in the lab looking at cells underneath the microscope. It's a very long and complicated process from when the drug is actually discovered in the laboratory, tested in mouse models, and then gotten to the patient itself. So it's not easy to have a clinical trial. That from when a doctor thinks about it or a scientist thinks about the trial, the drug is actually tested in mouse models until it gets to a patient is about 8 years. It's a long time. So lots of different things have to happen in that course of those 8 years to make sure that it's safe to give to a patient. There's lots of different kinds of trials. Dr. Shah alluded to them a little bit. There is the screening trial. Those are things that we use to do to develop new methods to look at how to diagnose diseases. I'll use the example of a PET scan that many patients have. Myeloma patients don't have PET scans because it doesn't work in myeloma. But it does work in solid tumors, and because of some trials that were recently done through ACRIN, the American Society of Interventional Radiology, there is now more payment for PET scans. Patients don't have to pay out of pocket for it because it's been proven to be beneficial in the solid organ cancers that are happening. So there's trials that are being done that are helping move forward the process of diagnosing cancers. There's the prevention trials. Many of you may have heard of some selenium trial that was used to determine whether or not that would help with prostate cancer. That's ongoing, or that was ongoing. And then there are colorectal cancer trials, whether or not aspirin helps. So there's all kinds of things that are happening in the trial world that help develop our method to either prevent or to screen cancers. We're talking today about the treatment trials and how we test those treatments. And then for me as a nurse, an important component of trials is the quality of life trials. How is it that we take care of patients all day long and fail to recognize that how they feel, how they're able to function with their families, we leave that part out a lot. And so for me, quality of life trials are very, very important. The phases of clinical trials are threefold. Before it gets to, as I said, before it gets to actually a patient, it's discovered in the lab, tested in the lab, and then it comes to a phase 1 trial. There are very limited numbers of patients who are enrolled in the different cohorts or the subgroups of a phase 1 trial. 15 to 30 people. So 15 to 30 people enroll in the trial, they're given the drugs, their information is evaluated by the clinician and the investigators. They stop the trial for a few weeks and look at the toxicities that are reported. How many of you pick up medication at the pharmacy and read the handout that the pharmacist dutifully gives you with each medication that you get? Right? So we look at all those things and we say, oh gosh, this medicine might cause diarrhea. This medicine might cause fever. This medicine might cause yada, yada, yada. The yada, yada is because during the clinical trials, that was reported as the toxicity in those trials when that drug was being developed. So you are a recipient of information gathered during a clinical trial. So you can take those disclaimers with a grain of salt, because not everything does cause diarrhea, but a lot of patients will report that with new medication. Once patients, the safety and toxicity in phase 1, once it goes to a specific dose level, the maximum tolerated dose, the safest dose that we can give without causing a lot of problems, the patient then goes on to, or the drug goes on to a phase 2 trial. So it goes through lots of iterations before it gets to the phase 2 trial. And more people are enrolled in those phase 2 trials because we want to find out better what happens with those. Once that happens and they determine that there's actually really good results from the drugs that we're studying, those drugs then move on to phase 3 trials. Phase 3 trials is usually what most patients are enrolled in. What we do with phase 3 is to evaluate the standard care, the standard therapy that we know absolutely works with a particular disease. And we may add a new drug, or we may change the dosing or the frequency of the drug. So for example, Dr. Kyle spoke about the Velcade. And Velcade, when it was initially released, was given days 1, 4, 8, and 11. Now we learned that if we give it weekly rather than at day 1, 4, 8, and 11, we cause less toxicity. That's a result of a phase 3 trial. The promise of clinical trials is such that there's lots of things that have happened. People live longer, and people have better quality of life with that. My best example of quality of life is a drug that is not used in melanoma, but is used in pancreatic cancer, and that's a drug by the name of Gemzar. 28 years ago, when somebody was diagnosed with pancreatic cancer, you pretty much knew it was going to be 6 weeks to 6 months before somebody died from that disease. The best thing about Gemzar is it allows people to live their lives very, very well and for a longer period of time with less toxicity than the drugs we had available. Still doesn't cure the pancreatic cancer, but it lets them lead better and more quality and more productive lives. So Gemzar actually was approved on the basis of the improvement of the quality of life for the patient. So, moving through here, we have the opportunity to walk through a widely open door. The doors open to the discovery of promising new and targeted therapies. We heard that from Dr. Shah today, that they're actually looking at monoclonal antibodies that will help with specific targets. So you're sitting there saying, yeah, well, who cares? Why should I care? Well, I'm going to tell you why. I think you know why.